All right, hello everyone, and welcome to our SIGNA Masters live scanning session. This is our third and last session for the month of January this year. I'm Sylvan Adam.
My name is Anya Pofana.
And we are live from Waukesha, Wisconsin in our SIGNA Artist Bay. So without any other detours, we're going to be talking about our air technology today.
Yes. And first of all, we want to show you a little bit the scanner and most importantly, our air coil. That is what we will use for the following scanning session. So we are going to use the air coil, which I want to show here to the camera and really show all the advantages the air coil has. First of all, this coil is really, really long. It has 65 centimeter of scan range. So it's easy to cover on every single patient, the liver and the pelvis, like in one scan. It comes with 30 elements in total, and you can use that coil in any direction, which just really makes it nice to work with. So you can use the coil as shown, like lengthwise, or even when you have a patient with a large belly, or maybe you have to scan a pregnant woman for some reason, you can put the coil in the other rotation as well, and have all the advantages of having a flexible coil which looks like a blanket and behaves like a blanket. And we will show that really when the volunteer is coming on the table, that you are not forced to strap this coil down on the patient. You can just use it, put it on the patient, and it behaves as a blanket, that it really customize every single patient shape. Other use cases where we've seen these coils is to use that for any scan where you have to have a large field of view and you cannot cover it with normal commonly coil. So for example, you can use that for long bone scanning here in the humerus. And then you can use it also show that into the other camera there. When we have like a long bone scanning for the leg, you are now able to use just this coil, wrap it around the leg, and have even the chance to get two joints in one scan covered, which is really, really amazing that you finally can do that. So another last thing which we want to mention before we really start the nice scanning session here is the combinations method with these coils. So for sure, you can use it as a standalone coil, so AA only. You can use it, as we saw, like wrapped around. And since it uses the air technology inside of these coils, you don't have to worry about wrap artifacts and decoupling of signal. You can overlap as much as you want, and you will always have the best image quality. And then all the other scenarios where you can use it in combination with the PA coil in the table, which is really nice and which we will do for our live scanning session. And then even if you want to have maybe a large field of view around the plexus, which we can do during the live scanning session, we just put the air coil in combination with the head coil and the PA coil to have really a high channel count in the field of view, which helps us to have really nice accelerated images. Okay. That's what I want to show here, and now we start really with the fun part. We have one of our co-workers ready who is going to jump on the table, and we're going to start the live scanning session.
All right, we are going to set up the volunteer now. And to rejoin Anya's words, we have had extremely positive feedback from patients and technologists alike on the use of the air coil, the comfort it gives to the patients. And even us, having been doing volunteer scanning here in the building, we could tell the difference. And it's really a comfort both for the patient and the technologist. So here we'll be installing our volunteer on the table in the 21 channel head coil, 19 channel, I'm sorry. And we'll be positioning the 30 channel air coil on top of our volunteer in a configuration that will allow you to do multiple anatomies without necessarily moving the coil around. There you go.
So now we are using the air coil, and that is really now the easy thing you can do with the air coil, that you can overlap as much as you want. So for example, when you have a slightly larger volunteer and there's you cannot move the coil underneath the head coil as we see here, then you can just put it on top of the head coil and you would get the same image quality. You can overlap really much that you have all the coverage here. If you don't need it, the overlap that much, you can also like just resume by putting the coil wherever you need it. So that's all you have to do to make good images. And here we can just go ahead and plug in the coil. And we are going to start with a head scan. And then we have to use our one-touch application here for landmarking. So I only use my finger to do the landmark, and then our volunteer goes into the board, and we will start scanning the head, okay?
Great. So I'll be seeing you at the console.
Here's the squeeze ball. So now we are back in front of the scanner. And hopefully you can see us here as well. Perfect.
Perfect.
So we have prepared the protocol. So I just hit the start exam button. And we show you not only air in regards to the coils, we also show you air in regards to workflow and air in regards to image quality. So another part which is new to our scanners is something we call air touch for the coil recognition technique. So if you are a GE customer, then you are aware that we previously had always like coil combinations here on the lower right hand side on the user interface, where you had to really pick which coil modes would provide the best image quality. Now we do have air touch, and air touch means that we are using a software to help you to pick the coils. And as a user, you only have to make sure that you've plugged in the coil as seen here. You only have to select the icon of the coil, and then the system does the rest. And how does the system do that? The software we are using is whenever you start a localizer, we are generating a sensitivity map. So that's a calibration scan only for 2 seconds, where the system will really understand where the coils are on the patient, because in these 2 seconds, all the elements of the scanner have been turned on and all the coil elements in the field of view. So you don't have to think about, do I need the RAA coil for that scan or the PA coil? The scanner does that. And you see here, the lines have been defined and the system will pick the coil just needed for that hand scan.
And we have a question in the chat. Paul is asking if that's an example of air touch, the single touch for landmarking. I think it's the whole. It's the whole thing. It's the one touch here for landmarking in combination with what you're seeing on the panel that Anja just described.
Yeah. And also, like in the previous softwares, you always have to, like when you're using a floating coil, you always have to tell the system where you put the coil into the bore with an additional landmark. Now, since we are using air touch, there's no need to tell the system where the coils are, because we will let the system will find out by itself. So another air thing on the scanner we'll show you next is AirX. So that is our first deep learning which we had on the scanner, which helps for slice description. So with AirX, we've trained a model to recognize anatomy in the brain and helps you with slice description. So here you can see on the user interface that anatomical references can be picked, and we have many of those. So not only the ACPC line, we can also do the temporal lobe, the inner ear, the OM line, the orbits, optic nerve, pituitary, circle of Willis, and the system will help you with prescribing the slices. This is really huge for consistency. So think about your patients coming for a brain every X months because they have to have a follow-up because of an MS disease or a tumor, then there is no need for you to get the old images on the scanner, look how you've prescribed, and do that over again. Now, when you use AirX, you can be consistent because we are using deep learning, and the model has been trained to really understand these landmarks and repeat them over and over again.
There's a lot of increase in productivity and reproducibility as well. We've had a little challenge internally, right? We all try to compete with who would prescribe faster, the machine or us. Obviously, we've lost every time. But just to show that if you want to prescribe a whole brain, you just have to open up a sequence, just make sure the landmark is on par with your expectations and save it. So there's no input required apart from saving the sequence.
Yeah. And the nice thing is that we have so many landmarks. And just to show you an additional example, so here the inner ear has been prescribed, and I will zoom in here, maybe remove the shim, that you can appreciate how good the job is done by the tool. So there's no need really for you to look at the inner ear. Just simply save it here in the protocol, and the scanner will find where to prescribe the slices.
Yes. And just to mention that if your site, for example, is doing a slightly different angle, it's always possible to modify it after the fact.
Yeah.
Right? You can let the system prescribe it, and if you feel like you need to make a change, you can always do so. But this can be entered in the protocol, as Anya was saying, so no additional input is required.
Yeah. And all based on a 3-plane localizer. That is also something which I want to highlight, because there were other prescription helps before where always a 3D localizer was required. That always added up on scan time, and you always have to do extra scans. Now, the nice thing is that there is nothing for you to run additionally to your 3-plane localizer. And once the localizer is done, you have all the landmarks already found. So nothing to do. You can decide while scanning if you want to pick another landmark, and the landmark is there in a second. Okay, so we did the first sequence, which was our T2 propeller scan. We covered the entire brain with 4mm slices. We had really a good in-plane resolution. And the nice thing here, the scan time was only 1 minute and 49 seconds. So Propeller is our motion correction, which is available in all anatomies. So you can do that for brain, for joint scanning, even in the abdomen, and we can show you an example later on there as well. And the nice thing is that in our latest software, it comes also in all contrasts. So we can do that in a T2 contrast, T1 contrast, and PD contrast.
Yeah, that's right. We used to be only doing T1 flare for T1s, right, on Propeller, and now we have the ability to do proper true T1.
And that really helps you thinking about your shoulder imaging, where we always use Propeller. The T1 images were the ones which were still looking with some motion. But now, since having T1 Propeller contrast here as well, you can have the entire shoulder exam with motion correction. So what we do next is maybe just do a quick localizer in the plexus. I want to let the system figure out how the coils are positioned here in that area. And then we will do a scan, which I hated as a technologist, to do a plexus.
Oh, yes.
Yeah, because I never understood really why to do that scan, because I never saw the nerves everybody wants to see, and it was always hard for me. So we are performing their cube sequence, and when the localizer is done, we will talk a little bit more about which type of work we can use to accelerate.
Right, the brachial plexus, I remember, used to be a field application specialist, and every time people would ask your brachial plexus, you'd be wondering exactly what coil you would be using specifically, and if the sequences will look out, will render great, right?
Yeah.
It will always a little challenge, and I think now if I ask you to do a brachial plexus, I don't think.
I'm not running away anymore.
You're not running away.
Usually that was my preferred time to take a break of the day. Now I can confidently say I do a brachial plexus and I'm not running away.
So you've seen how easy it is to position the air coil, right, on top of the patient, and on top of the head and neck unit that we're using right here.
Yeah, and as we said, you don't have to like think about any overlaps, which also with older coils which don't have air inside, you had to always make sure that you avoid decoupling of coil signal. Now with this technology, you don't have to worry because it doesn't happen anymore. Okay, so I just want to focus your attention when we run the 3-band localizer here onto the outer view. So the scan is done. Now we're moving the table slightly to go to the ISO center of the plexus. And then you see here, after the normal steps of tuning the transmit and receive gain, we will do something again called coil calibration. And you see that just shows up for 2 seconds. Here it comes, and that is now the time where we create the sensitivity map. So already finished. Now we are really starting with the 3-band localizer. So now the system has the information where the coils are in that field of view. And the software also considers which pulse sequence you will run and how much it will be accelerated. So it knows when you have a higher acceleration factor, you might need more coil elements to maintain the same image quality. So nothing for you to do as a technologist, which is great. The system does that for you. And you can see now the lines and the coil coverage has been found. Here you can see it's part of the HNU. Here is part of the Air Coil, which is on top of him. And here is the PA coil in the table. And nothing to do from my side, which is nice. So we perform here the cube sequence for the plexus, and I just started. And then I will reopen it again to show you how we came up with a scan time of 3 minutes and 25 seconds. So it's a 3D volume, which is here prescribed in an implant resolution of 1.2 by 1.2 millimeter, and we go through the entire neck with 1.4 millimeter. So it's pretty thin. Usually, I would expect a way higher scan time than 3 minutes and 24 seconds. But with our HyperWorks method, we can accelerate these sequence to come up with a scan time of 3 minutes and 24. And we can combine HyperWork method. That is something which I'm really always using. So here, the first thing we've used is HyperSense, which is our CompresSense technique. And we picked a factor of 1.2. On top of HyperWorks, we also enabled HyperCube. HyperCube will be enabled here by setting the excitation mode to focus. And what we do then is we make sure that the system in encoding direction, which is the phase is right to left, doesn't read out more than the field of view displayed, which helps us to not oversample and not to gain any rep and the images. So I just want to like remove all the HyperWork from one sequence. So I removed the hyperfocus by just turning on the phase field of view. And if I would like really don't use it at all, I would have to use a no phase rep because the shoulders would be in my way. And then I would have to like want to remove HyperSense to show you without using HyperWorks, the scan time would be around 7 minutes and 16 seconds.
So it's more than double the time, right?
Yes. So who wants to scan like that? I don't.
Absolutely. If we can have the same results in 3 minutes 25, probably take the 3 minutes.
Definitely. So now we will show the cube sequence, which we did through the inner ear, just to see how nice the prescription worked.
So does this cube also use HyperCube?
Yes. So also here for the inner ear, we combined 2 acceleration modes. One, the hyper modes, because the phase field of view, as you can see here, was A to P, and it looks like it is cut off, but by turning it to focus, we don't excite here in that region, we don't excite here in that region, and we see that no proton is giving us any signal, which is really, really nice. And then we did also a CompresSense technique here on top of it, so that we ending up really with a scan time of 2 minutes and 31 seconds with a resolution of 0.8 millimeters. That is also something which is really nice for having thin slices for the inner ear ready in 2 minutes. That is something which you can add now easily to your routine brain without messing up your routine day, right?
And you can tell the plane is pretty good, right? Yeah. You use ARX for this prescription, correct?
Yeah, correct.
Mm-hmm.
Yeah, I couldn't have done it better. Or when I would have prescribed it that precise, I would have to run multiple localizers to find the inner ear.
I remember scanning a coronal T2, right,
Mhm.
to kind of assess where the how I would prescribe this 3D on the IACs.
So now we just move freely through the body. That is also something which is nice and way more improved since we have the new workflow with air on the scanner. So we just have the air coil also like on his liver. So I can just continue with maybe doing some liver scans here. I will run the localizer in his liver area. And again, nothing for me to change here. I don't have to deselect the head coil or anything. I just go ahead and run my 3-plane localizer because the system knows after the localizer where the coils are on the patient. And then we can continue with doing some free breathing scans in the abdomen. I'm not sure if you paid attention when we positioned the volunteer. I hope you saw that we didn't put any bellows on him. So usually when we had to do free breathing scans in the past, we had to use bellows and put them on the patient and fix them on the patient. Now we can use a technique called Navigator, which is also software-based gating. So nothing for you from your side to put on the patient. You can just put the air coils on him. And also there, hopefully you saw that we didn't have to like use Velcro straps to strap the coil down. We can just use the coil, put it on him, and it fell around his anatomy without fixing it.
Yeah. And I think the system just this localizer we're doing was a breath hold localizer, correct? Yeah. So the system just automatically asks for a breath hold,
which is nice. So here the plexus images show up. We will show them in the 3-plane viewer here as well. And then I'm going to prescribe the first images here in the liver. So the first thing I want to like highlight is that there was nothing for me to do in order to prescribe the navigator. So this software, the tracker, has been placed by the software because we put here a post-processing task, which is called auto-tracker placement, so that the tracker has been placed by the scanner and not by the technologist. So again, like really a nice workflow step, which helps you to use that feature with Navigator without being forced to prescribe it. That is also something when you would have to do that as a technologist, you have to run maybe 3 localizers to understand where the diaphragm is and how it moves. But here you have to run the normal 3-plane localizer. You just have to make sure that you cover the liver. And in 99.9%, the system is doing a great job in finding the tracker and positioning that on the diaphragm. Okay, so now we have some more fun images here. We just did the plexus, and for the plexus, we did cube with flex, which is our Dixon technique. And I just want to show you really the thin slices first. Maybe we go to a large view. But now when we bump up here, you can see how nicely you can see really the nerves. And since we had the air coils on top of it, we couldn't follow the nerves until the entire arm. Now it's fun to do, right?
Absolutely. So it was just one sequence, 3 minutes 25. Patient positioning didn't take too long, right?
Yeah.
This is great, and that's a Dixon technique. So we also have access to the in-phase image.
I can just maybe show all the results we got. We got also a fat image, which is maybe not that helpful, but it's still acquired. But the nice thing is that you have like a real contrast here too with an in-phase image and also an post-phase image, all generated in 3 minutes and 24 seconds. So here you see the navigator really working. I just highlight here that window because I really think this is also makes your life as a tech so much easier. The navigator is running, and you can see that while scanning, you have access to it too, which is huge because let's be true, what is happening in real life? Your patient is on the scanner and he's not breathing like our volunteer who is able to do that easily. most of the patients are really excited going into the bore, and then they like really get slower with the breathing pattern because they know after 2 or 3 minutes that it's not a big deal to do an MRI scan. Then you as a technologist see that the breathing pattern change and the green curve will never reach the threshold anymore. And then the scanner will pause and you have to do it all over again. So here with our navigator, you see the threshold, the red line is accessible here with that window. So while you see the breathing, you, in case the breathing pattern will change, can lower the threshold while scanning. So that really is huge in regards of your patients, because you can always make sure that you will like have the entire scan done in one approach. Okay, then maybe 2 more things. I think we are already close to the end. Just maybe a few more advantages in regards to the Air Coil, which I want to highlight here. So you saw, first of all, the versatility is great because you can like do abdomen, you can wrap it around long bones or whatever you want. The other thing which is really huge is that you have way more acceleration factors available with these Air Coils. So since we have now 30 elements in the front and like 40 in the back from the table, and what we do here want to show is, I just show it on a few slides. I want to cover the abdomen here and scan with an acceleration factor by 2. So we have a breath hold time of 12 seconds. And I want to do the same sequence. I will copy it from the other one, and I will want to do exactly the same. But here I want to accelerate higher. So here I use an acceleration factor by 3. So the scan time is like reduced by 3 seconds.
3 seconds. So it's a fourth. It's a fourth of the sequence time, right? It's 25%.
And you will see when we compare these images that the image quality will look exactly the same. So, and that is where I really see another huge advantage of having so high channel count in the field of view. You have way more possibilities to accelerate. And if you are familiar with our older coils, then you can see that that you in the past you couldn't accelerate higher than 2. But now when you have high channel counts in the field of view, you are now allowed even to accelerate up to a factor of 3. Okay. So the propeller is gone through, and maybe as a note here too, we've scanned in the abdomen the propeller. And that means we did like kind of 2 combinations at once. We've used our motion correction with propeller. And then what we also did is we used navigator. So it's really a nice sequence where you have less motion. And I will show you the images here in a second. And good for the patient too, because he could entirely breathe as he wanted the entire time. You see our volunteer was a bigger guy too. He has like 240 pounds. And see that the fat situation is in the abdomen really well. And there's almost no motion because we can combine propeller sequences with navigator.
And to say, you were showing a navigator earlier, we could also use the navigator for 3D T1 sequences, right? So what we have, Lava Flex, which is our 3D T1 Dixon, but also Disco, high temporal resolution, 3D T1 and Disco Flex can also all compatible with navigator.
And that's really huge that you can offer an entire abdomen scan in free breathing. So there's not one sequence which you have to which you cannot run because you are not able to do that in free breathing. Now you have every single contrast you can think of in free breathing. So here now as a last example, we did the 2 single shot sequences with the different acceleration factors, and I want to show them in comparison. Left-hand side, you hopefully see that here in the scan time was the acceleration by 2 in 12 seconds. And on the right-hand side, the same sequence, nothing has been changed, same resolution, everything's the same, but we used the acceleration of 3 in 9 seconds. And you see that the image quality is the same, so you don't lose anything when you accelerate higher.
Yeah, absolutely. It's actually most likely going to look even a little sharper because when you add acceleration on a single shot, usually you have less blurriness, correct?
Correct.
Yeah.
Perfect. So maybe we will ask if there are some questions from the audience. If so, feel free to use the tab feature and ask whatever you.
If you have any
want to
questions,
know.
yeah, please go ahead. There's a chat available in the Teams meeting. We'll be happy to answer any questions you have. So in the end, we reviewed all of our air technology. So we went with Air Touch, which is a easy coil positioning and no-brainer positioning without having to use the coil selection, as well as AirX for easy prescription, slice prescription in the brain, and our air to coil technology.
Yeah, and the coil is the big starter where everything started with, and that really makes scanning so much easier now.
This is great, and I see that we can also we could almost, without moving the collar, go to the hips, right, and do some hip scanning too.
And he was a tall guy.
And he's a tall volunteer, absolutely. We went from brachial plexus, which is all the way here, down to the abdomen, and we could do prostate and hips probably without having to move the coil.
Perfect. So thank you for your attention and joining us today. We will continue doing live scanning sessions spread out through the year. We will announce them shortly, and hopefully you will listen to us soon again. Thank you so much.
Great. Thank you, everyone. Have a great rest of your day.
Bye.
Goodbye.